So we're here again talking about cognitive biases and things that they may create as far as the stories that we tell within the osteopathic profession or within other manual therapeutic professions. So the reason I'm at the top of the table is because I want to talk about things such as the OA. So in osteopathic practice, you will hear people talk about the OA, or the occiput on the atlas, aka the first cervical. So the head on the top of the cervical column. Okay, you'll see people come in with their hands broad. They'll come in underneath, and they'll basically put their fingers up. Okay, and then what they'll do is they'll hold for a period of time. You'll have people say that the weight of the head will essentially create a release of the sub-occipital muscles. You'll have people say that over the fingers, what you want to do is not only use the weight of the head, you also want to create some traction. So I don't know if you'll be able to see it in my arms, but I can basically bring my arms back. So if you actually pay attention to my thumb, if I keep my thumb where it is, you'll see there's a possibility that I may slide over his skin, but his head won't move that far. Okay, but basically I can feel, I'm just going to turn his head a little bit, right in here, I can feel some of the occiput. Now the occiput essentially goes way, way forwards. If we actually had a skeleton, we could show you that more accurately. It goes way forwards. There's a lot of thick musculature here. Okay? So you have things like the trapezius, not so much as a thick muscle in the levator scapula, but the trapezius is quite thick, the levator scapula is there, the splenius is there. We've got a lot of thick superficial muscle that's going to attach into the nuchal ligament, or the ligamentum nuchii, or however you like to use your Latin, which I'm not an expert in. But what you'll have is people they'll palpate through the occiput and they'll push the tissue anterior. And then what they will say is things like they're performing an OA release, or a release of the occiput away from the first cervical. They will say that they are treating very specifically the very small sub-occipital group. So there's 4 muscles in there. Actually, I think there's more. But I get a little rusty sometimes, especially when I have to talk out loud. But you have very, very small muscles in there called the sub-occipital muscles that respond to the oculocephalogyric reflex. So the eyes will move, and then these muscles will respond by keeping the head level with the horizon, or at least the eyes level with the horizon. Okay, so they're highly reflexive muscles. You'll have people holding in here and saying things like, I'm releasing the sub-occipital muscles. And we don't know that that's actually true. Right? What we do know is that we can palpate the superficial musculature, so things like the trapezius, things like the splenius, and we can definitely feel softening through those. But the actual sub-occipital muscles are quite small, so we're not sure 100% what effect we may or may not be having on them. Now, in this region, you have the head joining the cervical column. You will have close proximity to the brainstem, or close proximity to the cerebellum, the midbrain, the pons, medulla. If you actually look at the anatomy. Now, what you're going to have people claim is that they're treating those things. There are some that will claim when they treat the occiput on the first cervical, or when they create a release of the soft tissue in the region so that that soft tissue alters its tone, aka it softens, and then the occiput moves better. What you'll have people say is that they released the Vasomotor Center, the chief Vasomotor Center. So the concept of vasomotion, at least classically, is that there was one center inside of, I believe it was the medulla, that controlled tone of all blood vessels body-wide. So people believed that if there was a vascular issue, they could treat the first cervical, or the occiput on the first cervical, and then alter how the blood vessels were working through the full body. What we know is that the vasomotor center is not specifically in the medulla. It's at best, or best described rather, as a dispersed network throughout the brain that generally controls general vascular tone within the body, right? So overall, the vessels will have a certain general tone, but that discounts or doesn't speak about what is currently known as vasomotion, which is essentially local auto-regulation of blood flow, independent of heart rate, independent of respiration, and independent of the nervous system. So in any given area, we can have alterations in blood pressure or blood flow that is completely independent of outside influences. It is very, very local. So treating the occipital on the first cervical does not necessarily affect blood flow here. It has at least some chance, if we can prove that there's a mechanical obstruction between the occiput and the first cervical that is altering body-wide tone, which we can't always prove, or may have a very difficult time doing. It's possible that we could affect overall tone, overall vascular tone, but we're also ignoring the the effects of total peripheral resistance and general muscle tone, we may actually have a better opportunity to affect general blood flow or general vascular tone by softening soft tissues distal that are creating increased total peripheral resistance. So we may actually have a better time doing that. But you'll get people saying that they're releasing the medulla or they're treating vasomotion, that is the chief vasomotor center. And these things are information that once were the best information we had, but now is not the best information we have. We have other information that's newer. So if we look at the concept that we've spoken about before of theory-induced blindness, if you believe that there is a chief vasomotor center and it is essentially located proximal or very close to the occipital and the first cervical, you can believe that you are affecting general vascular tone. If you have newer information that suggests that that vasomotion or the vasomotor network is a dispersed network throughout the brain and it does have some locations in the medulla, you're less likely to think that a treatment of the first cervical and the occiput in their relationship is going to affect that. You're going to think about things like total peripheral resistance, local autoregulation of blood flow, and things of that nature. So you may have a greater effect on blood flow in a local setting. So you would treat soft tissues that would be putting localized pressure, especially on veins, somewhat on arteries, and the arteries would have to respond by essentially creating an increased pulse in the region. But what we really want to say here is that based on anatomical information that's just correlational, right? That, or at least in the past was correlational. Chief vasomotor center is in the medulla, the OA is close to the medulla. If I treat the OA, I treat the medulla. Those are essentially associative stories that may not necessarily be as accurate as we would like them to be or as accurate as they should be given today's information. So we want to keep our eyes out and be careful that we're not just saying that I have these pieces of information, I associate them, so that would be essentially what you see is all there is, and then I have this theory that the chief vasomotor center is there, or I have this theory that if I put my hands on the superficial tissues in and around the posterior or the superior and inferior nuchal lines, or what piece of the occiput that I can actually palpate, and then the soft tissues in and around it that I can palpate, that I'm definitely releasing the suboccipital muscles, because I don't know that I'm doing that either. I know that what I'm touching superficially is things such as trapezius and things such as splenius and other muscles, and that I can create an alteration in their tone, but I don't know for sure that I'm treating sub-occipital muscles. I can tell if I move the head on the first cervical, right? This is one way to do it. So essentially I can wrap my hands around the occiput and I can move the head. That may not work the way I want it to. I can take a pistol grip or a yoke hold. I can wrap that around the base of the occiput and I can move the head on the first cervical. And while that is one of the better ways to do it, it may not be perfect, it may not be exacting, but I can move the head in relation to the first cervical. What I'll know is that I've created more motion between the head and the first cervical. If I've tested it, if I've treated and I've retested, what I don't know for sure is exactly what happened. I don't know for sure if I changed general vascular tone. I don't know if I changed endocrine pathways between the brain and the neck and the rest of the body through the vascular system. I don't know if I treated sub-occipital muscles. I do know that movement's improved. I know that for sure. So again, we come back to the concept that in osteopathy or other manual therapies, we test movement. That's what we definitely test. Everything else we're telling, as it stands, is more likely than not, an associative story, or a story that allows us to communicate with other people such that they can connect with what we're showing them. So if I'm showing them a test of the occiput on the first cervical, I can then tell them a story that I'm treating the medulla. I can tell them a story that I'm affecting vasomotion. I can tell them a story that I'm treating the sub-occipital muscles. Well, they're there, so why wouldn't I be treating them? Well, what I'm suggesting is that we back off of that until we have further information that suggests it's definitely true, or that it's true within a very narrow frame. How do we do that? We look to people who know how to appropriately create research projects and appropriately test these things. And it may not be the easiest thing to do, but it'll be coming in the future because we want to know why, when we treat somebody with manual therapeutics, specifically osteopathic manual therapy, we get these seemingly related results. Somebody has a lack of motion somewhere, they also have other symptoms. You create an improvement in that motion or that lack of motion, and then you, in a temporally related way or a way that's related in a time frame, it seems like the symptoms change. And we want to know what's actually going on there. So we'll continue to push forward with it. What I'm suggesting, though, is we be careful with the stories that we tell when trying to essentially deliver the message of, how do I do this? What's happening? We want to be very careful with that.